Assalamu alaikum. I would like to thank the organizers for the kind invitation. This is a very important session on hepatocellular cancer. So far, all of you have heard about local regional therapy, resection, and liver transplantation. However, the field which is growing significantly in the last few years is systemic therapy for hepatocellular cancer. My goal in the next 20 minutes is to discuss about what is new based on the latest studies and how in the United States and also rest of the world, we are thinking about these patients with advanced hepatocellular cancer. Before I start, I just wanted to show my disclosure. However, very upfront that I am not an oncologist, and a lot of these patients who need systemic therapy are managed by oncology. When we look at the AASLD guidelines, which was published in 2018, they used the different Barcelona stage and talked about what are the treatment options. And many of the speakers before me in this session have talked about the Barcelona stage and how we make the decision based on the staging and what the treatment to be offered. What I wanted to focus on is that since 2018, there is already a significant change in the first-line therapy for hepatocellular cancer for systemic therapy. And also, we are thinking more about that patients who need systemic therapy to start it more earlier on. And that's a paradigm shift that we will be started seeing. This is, modified from ASCO, and I, borrowed this slide, which actually showing, again, the similar for the Barcelona stage, but one point I wanted to focus on that now there is an increased attention to start systemic therapy more earlier. In the past, we were using only in advanced cases, using a lot of intra-arterial therapy. But what we have found out that there are certain patients who would be benefit to start systemic therapy early on, especially when we worry about that because of their cirrhosis and advanced disease, there may have more concern for decompensation of the liver, and they may not tolerate the systemic therapy if you move forward. So this is a shift that we are seeing, but important point is that whenever we have a patient with hepatocellular cancer, we do discuss it in our multidisciplinary tumor board. Having an input from all the specialists is key to have the best outcome and the best result for our patients with hepatocellular cancer. So the most important thing and essential thing is, like many places in the United States, that we have what we call tumor board or multidisciplinary committee, where we have our surgeons, transplant specialists, oncologists, hepatologists, radiologists, and interventional radiologists. As in some cases, there may be an input from the pathology, but we all are trying to figure it out. What is the best treatment option for an individual patient? And although we have Barcelona stage, we have many different algorithm, but we have to think about the patients. We have to think about what is the status of the liver diseases, what the child score is, what decompensation had it, what is the performance status, whether the patient can be a candidate for resection, local regional therapy, and having an oncologist in the tumor board help us now starting systemic therapy much earlier. There is a good amount of data that if you have a multidisciplinary care, it does improve hepatocellular outcome and survival. So I have an idea that there are a few places in Pakistan who has a multidisciplinary tumor board, but I just wanted to again bring it into the main highlight that every program who is managing patient with hepatocellular cancer should have this multidisciplinary tumor board so that a patient can be discussed and the best treatment modality should be offered to that patient. Now let's talk about what is the evolving field, rapidly evolving field of systemic therapy in hepatocellular cancer. This is a busy slide, but it clearly shows that most of you know in the first line is the first line therapy, and then we have second line therapies. Now the first line therapy in 2007, based on the SHARP clinical trial, sorafenib was the first systemic therapy which was approved for hepatocellular cancer. And it took almost 11 years, more than a decade. It's just like Pakistan cricket team when they first won the Cricket World Cup in 1992. It took us 17 years until in 2009 when we won the T20 World Cup. So this is a similar, like, it took a lot of time. But once in 2018, lenvatinib was the second agent which was approved as a first line for treatment of hepatocellular cancer. And latest kid on the block, and depending on where approved by FDA or EMA, that based on IM Brave 150 study, which we're going to talk about, that atezolizumab and bevacizumab was approved as the first line therapy. And now most of the patients, this is the recommended or preferred first line therapy for systemic therapy for hepatocellular cancer. Then there are patients who either had progression or they did not tolerate sorafenib. So there are other second line agent, regorafenib, cabozantinib, ramucirumab, the combination of nivo and ipilimumab, and then the other agent which was approved now in China is camiluprimab. Is also, these are the agents which has been approved for second line therapy. So from 2007, when we only had one agent, we had a lot of failures in between, but finally we have big armamentarium of our newer agents, which are very important in improving the survival in patients with advanced hepatocellular cancer. So let's talk about the first line agent. As in the prior slide, we have options of sorafenib, lenvatinib, and the combination of bevacizumab and atezolizumab. Oral agents are both sorafenib, lenvatinib. These are tyrosine kinase or TKI, and then you have these wedge inhibitor, and then the combination is the PD-L1 inhibitor, and we will talk about individual. Few concept of systemic chemotherapy. When we look at these clinical trials, they obviously the first thing and primary outcome in some of these trials are obviously overall survival, where the patients have increased survival when you are either in treatment or combination. Then there are two other concepts are important. One is progression-free survival, that you don't have a progression, although you still may have cancer, but there's no progression of liver cancer. And the third is ORR, which is overall response rate. Tumor assessment in these trials or most has been done by modified RECIST criteria, which is modified response evaluation criteria in solid tumor. So when you look at these studies in systemic therapy for advanced cancer, they talk about OS, which is overall survival, progression-free survival, PFS, or ORR, overall response rate. The SHARP trial was the game changer early on in 2008, when it was published in New England Medical Journal. And what it shows that patients with advanced HCC, sorafenib have an improved overall survival, about 3 months, you can say 10.7 months in sorafenib versus 7.9 months. But the hazard ratio was impressive. And based on this, the sorafenib was approved, and there was also an Asian trial, which although less survival benefit, but it still was good enough that it was approved based on the SHARP trial overall survival as the first line agent for hepatocellular cancer with advanced disease. Now, the second agent which was approved was REFLECT trial, and that is a non-inferiority trial, meaning that the goal was whether the lenvatinib did the same thing as sorafenib or don't do the less. And based on this clinical trial, the lenvatinib, which is 13.6 overall survival, or again, I mentioned OS, versus 12.3 months, and the hazard ratio was 0.9. And based on this, lenvatinib was approved for a second agent to be approved as a first-line therapy for advanced hepatocellular cancer. The one point is that you can compare it that since I think we got better. Our oncologists, we are better in managing patients with liver disease. So if you compare the same, the outcome, and even sorafenib arm of about 12.3 was much better than 10.7 months. So that is, so lenvatinib was the second agent which was approved. We look at the clinical factors that how we decide, at least in these two agents early on. We do have phase 3 clinical trial on both these. The inclusion criteria was Charles A cirrhosis with a good performance status. One point to note in lenvatinib that patients, although had Charles A cirrhosis and good performance status, they excluded the patients with greater than 50% liver involvement and whether the main portal vein was involved for bile duct invasion. It does not mean that this is not going to work, but they did not include these patients in the clinical trial. There is also improved survival versus placebo in efficacy in sorafenib and non-inferiority as measured. In addition to not only have improved survival, it's a same survival or non-inferior survival versus sorafenib. Lenvatinib study showed that there was an improved objective response and time to progression compared to sorafenib. The side effect profile was important to know because patients on sorafenib, as we know, have major side effects, especially most commonly diarrhea and increased hand, foot, skin reaction, which has a significant quality of life impact. In lenvatinib arm, it was increased hypertension, proteinuria, and anorexia. These are both, sorafenib is oral twice a day, taken 1 to 2 hours. And then lenvatinib is oral once a day and can be taken with or without food. Although the studies have been done on sorafenib in Charles A, there is a real world effectiveness data in population Charles B cirrhosis. Although Charles C cirrhosis is a contraindication, there is some data coming out, have some benefit with reduced dose, but we need to still wait for more studies to come out. Now, the game changer for now in 2021 was this IM Brave 150 trial, which is atezolizumab versus bevacizumab. And they also compared versus sorafenib for the first-line treatment for hepatocellular cancer. It's a multi-center randomized open-label phase 3 clinical trial. Again, Charles B and C cirrhosis were excluded. Patients with locally advanced HCC or metastatic or unresectable with no prior treatment, Charles A, good performance status 501. And the primary core primary outpoint was endpoints were overall survival. So they had two arms, 2 to 1. With atezolizumab and bevacizumab versus sorafenib 165, and the treatment until patients have this overall survival. So the important updated data, although they did publish one and they got a expedited approval, but then the updated data, which was presented in ASCO meeting and also now published in a journal now, is that the atezolizumab and bev arm has much better overall survival, median of 19.2 months as compared to 13.4 months, which is statistically significant with an excellent hazard ratio. And you can clearly see the benefit of the combination treatment versus sorafenib. And based on this data, now the preferred first-line treatment in the US is the combination of atezolizumab and bevacizumab. It does not mean that sorafenib, there are patients, there are certain contraindication or exclusion in the atezolizumab, bevacizumab arm, especially there were patients with autoimmune disease, which was not like most of these trial, they didn't have advanced disease. So patients who have advanced Charles B or C still have sorafenib arm. So that is some of the patients that may be still using sorafenib. I did not look into it whether this combination is available. I don't think so in Pakistan, but this is the future right now of systemic therapy as a first line in advanced HCC. Not only that, that they have a better overall survival, the quality of life is also much better in the combination treatment. And I just wanted to focus on one thing, that if you look at the symptoms as compared to sorafenib, the diarrhea was lower. There is definitely, hand-foot syndrome, which is much higher in sorafenib. And the hypertension, proteinuria is more. So symptomatically, patient on sorafenib has poor quality of life because diarrhea and hand-foot syndrome and skin rashes were definitely patients seeing more as compared to hypertension or proteinuria. And so that is the one of the factors that look into it. One thing is also very important that these patients who are in this combination, there were slightly more increase of GI bleeding. So we do recommend violation for varices, and based on the guidelines, if you can treat the varices, that would be good before starting the treatment. So when you look at the landscape for advanced HCC, in 2020 was different, but now the 2021 is basically we are going more toward atezolizumab and bevacizumab arm. So what options do we have if there is a progression of HCC on the first-line agents? We have now many second-line treatment options, cabozantinib, regorafenib, especially patients who had progression on sorafenib, ramucirumab, nivolumab, and then you have combination agent and also camrelizumab. We don't have time to go into each individual studies, but this was just to give you an idea of a second-line agent. There are three important trials: the resource trial, celestial, and reach2 trial. Which the resource are regorafenib versus placebo, cabozantinib versus placebo, and ramucirumab. Important point is that what were the reason for discontinuation of the first-line agent? In resource, which is a sister drug of sorafenib, regorafenib, there was a radiological progression on sorafenib. The other agent is that either progression or patient did not tolerate sorafenib. As I mentioned, there are significant side effects on it. And they have different target like tyrosine kinase inhibitor, cabozantinib, and then you have monoclonal antibody. And the prior treatment and all these were sorafenib at that time. One point to note that patient with ramucirumab, alpha fetoprotein of greater than 400 is one of the indication that has been used if someone has a greater than 400 alpha fetoprotein that has shown a better benefit as a second-line agent. With this compound. So if you look at, it's not head-to-head, but just a different trial versus placebo as a second-line agent. So this was the regorafenib, 7.8 in a placebo versus 10.6. If you look at the celestial trial, there were two different trials, but it shows also a benefit or improved overall survival. And same with the reach2 trial with ramucirumab, that you have an increase in survival. And not only that you have better overall survival, you also have a progression-free survival. So patients who failed the first-line therapy, now we have many different second-line therapy, which has also had improved survival and progression-free survival based on different studies. So what are the different options that which I have mentioned? So the inclusion criteria, how we use it, that patient who tolerated sorafenib but with radiological progression. Cabozantinib is a phase 3, which is intolerant to sorafenib with or without, could have received an additional line of systemic therapy. And ramucirumab, that patient with greater than 400 alpha fetoprotein, and they have improved overall survival, and side effect profile were similar in both regorafenib and cabozantinib arm of the TKI, and ramucirumab is well tolerated with low rate of dose reduction or discontinuation. These are both regorafenib and cabozantinib are oral agents since they're TKI, as compared to ramucirumab, which is IV infusion every 2 weeks. So other second-line agent which was approved based on the Checkmate 040 study, which I know that is available, very expensive in Pakistan, is nivolumab. And this was early analysis of phase 1 and phase 2 Checkmate, which has 182 patients previously treated with sorafenib, which has this median overall survival of 15.2 months. And based on that, it was initially have an expedited approval for a second-line agent for patients with HCC. And these patients have manageable safety profile and no maximum. However, the phase 3 clinical trial did not meet the endpoints. And based on that, nivolumab, which had been given the accelerated FDA approval into April of this year, 2021, there was an oncologic drug advisory committee who was voted against the continued acceleration approval of nivolumab in America for treatment of HCC who was previously treated with sorafenib. And so we have to wait for the further studies, but this is, although the combination agents have been used, and we have to wait for those results. As it's not only that what we have as a second line therapy, there are many different studies that has been going on as not only as a first line as well as the second line agent. And the one thing that you would be noticing is that a lot of these or most of these trials are combination. And I think that is a new trend, as especially with the approval of atezolizumab and bevacizumab, you will see that we have these study of phase 3 cosmic study, as well as many different agents like PDL1 and TKI. So bottom line is the future of systemic therapy would likely be a combination agent. And this is gonna increase the survival, and these compounds so far has a better safety profile and also have good quality of life. So we have to wait for a lot of this. One thing is for sure that just like when we had these new Hep C treatment, every year there would be a new development. And every time I present this talk from last year, there is a change. And so, but this is very exciting for our patients with hepatocellular cancer. So in conclusion, at this time in 2021, atezolizumab and bevacizumab should be the first line systemic therapy in most patients, although there are patients population who will continue to receive tyrosine kinase inhibitor, sorafenib, and the other agent. There are now multiple newer agents approved as second-line therapy for advanced HCC. One exciting thing is that the survival for advanced HCC, which was very poor, now increasing to 24 or much higher now. There are other studies that are coming out. So these patients have an improved survival with these combination of first and second-line therapies. Important thing is that we do need a very coordinated care essential for preparing and managing the patient with cirrhosis in treatment. If patient has advanced cirrhosis, so I have seen scenarios that patient was just sent to oncology and GI and hepatology were not seen, but their liver disease were progressing. They have other factors, so it's very important that the gastroenterologist and hepatologist should continue to be an important part of their management and manage the cirrhosis in this group. We have to have multidisciplinary committees and tumor board to make individual decision. Hopefully in the future, precision medicine may come into the play in the treatment of, and we would like, just like other biomarkers and just like lung cancer, we can have targeted therapy. Cost and availability will remain a major barrier in many countries, including Pakistan. This is the end of my talk, and I hope that we can have a further discussion and talk more about it during the question and answer session. Thank you so much.